In the U.S. in 2020, the number of people who died from a drug overdose spiked by 30%. Between May 2020 and April 2021, 100,000 died from an overdose. The rise is attributed to synthetic opioids, stimulants, and use of multiple substances in combination, and is known as the fourth wave. What started in 1999 largely with prescription opioids continued in 2010 with heroin use. Then by 2016 was driven by lethal synthetic opioids like fentanyl. And by 2020, stimulants like methamphetamine and cocaine, and depressants like benzodiazepines were being combined with fentanyl to cause record numbers of overdose deaths. This polysubstance overdose crisis has also struck Appalachia, where in 2020, more than half the calls to poison control across 23 rural counties in Kentucky, New York, Ohio, and West Virginia involved more than one substance.
The fourth wave of the overdose epidemic, initially was attributed to stimulants and fentanyl use. It's pretty much now fentanyl is in almost all the drugs. You have adulterated pills on the street, so anyone buying an oxycodone 30 milligram tablet, they think they're getting oxycodone. Really, they're getting a bunch of fentanyl.
We're seeing an increase in counterfeit pills and overdose deaths nearly everywhere. So in urban communities as well as in rural communities, including areas in Appalachia, in Ohio, Kentucky, West Virginia, the southern tier of New York.
Even when heroin was truly heroin, there was some variability in how much was in a bag, but people generally had an idea on how it would affect them. Now they get fentanyl, and they may get a lot of fentanyl in the bag, or they may get a little fentanyl, and it's when you have an opioid as potent as fentanyl, and sometimes mixed with other things that are going to make it stronger, potentiate it, it is really dangerous and really unpredictable.
I've experienced 2 overdoses. Both times I went and I'm gonna buy a small amount. Usually I would do, let's say, 5 bags of heroin at a time. Well, this time I'm only gonna do 1 because that'll keep me safer. I'll still get an effect from it, but I'm not doing so much, so that'll kind of better ensure that I don't overdose. And I couldn't even tell you what force it was that made it so that I could still be here because I was driving my car. I pulled out of Tops on North Clinton, and the next thing I know, I'm getting yanked out of my car by EMTs up on Main Street. I have no idea how I got to Main Street. I don't remember any of it. And I was just stopped in the middle of Main Street. Like, my foot wasn't on the brake, I wasn't in park, I didn't hit anything, my car just stopped. And somebody luckily had Narcan on them, called 911, so they gave me some Narcan. I wasn't quite responding to the first dose, but them giving me that Narcan kept me alive, we'll say, long enough for EMS to show up and give me more Narcan, and then I was brought to the hospital. But when they did my toxicology, it was all fentanyl.
We get a lot of unintentional overdoses because people don't know what they're getting. In the last couple of days that I was on consult, I had 1 each day. One was a patient that had been in a bar, bought a line of cocaine, and woke up in the ED. She was with somebody that had naloxone, and fortunately was able to be reversed, but had she been in the bathroom without someone around, it would have been a fatality.
I had a therapist tell me one time, and I hold this very true and remember it because the way he presented it was very, very blunt and direct. I was complaining because I had to do a screen and outpatient, and I was testing positive for substances that I didn't use. And I was complaining about this. I had a problem. Well, I didn't do that, and that's not fair. I think it was cocaine. I didn't use cocaine. And he looked at me and said, well, yeah, the quality control on street drugs has really gone down. And meant in a sarcastic way, but it really kind of illustrated the fact that you can go to the same person and buy your substances and feel like you're safe in that, but there is no guaranteed safety out there, and that those threads that we're holding on to convince ourselves that we're keeping ourselves safe or safer are starting to become thinner and thinner and thinner, and in a lot of situations, they just break.
So the counterfeit pills are dangerous for a number of reasons. People, and probably the most common counterfeit pills I see are alprazolam or Xanax. Alprazolam is a very euphoric benzodiazepine. People really like it. So it's a known commodity. It's not surprising that someone will press a pill to look like Xanax, but they don't contain alprazolam. They contain other synthetic benzodiazepines, sometimes mixes of designer benzodiazepines that the end user doesn't have an idea of the strength often, the duration of effect. Sometimes there's other things in it. There have been clusters of fatalities with designer benzodiazepines that had fentanyl mixed in it. So if you have a user that's expecting to use maybe a 2 milligram dose of alprazolam, that they know what happens when they take it, and they get a much more potent designer benzodiazepine, maybe mixed with some fentanyl or some other drugs, it's a perfect setup for overdose and fatality.
I know that I would seek out prescription medication off the streets before heroin because I felt like, well, if it's prescription, like chemists put this together, the FDA approved it, whatever, I know what I'm getting then. And now with counterfeit pills, that's completely changed the game. And I have seen people buy counterfeit pills that they think may be Vicodin or Xanax, and it turns out that it's completely just pressed fentanyl.
There's a stabilization phase in treatment. For a lot of people, a lot of times that initial process is getting some medication, getting stabilized physically, and then they can really focus on some counseling that can help them look at recovery on a more long-term level and figure out what is their pathway to recovery.
The withdrawal, the dysphoria, anxiety, panic, all those symptoms, people are often, once they're physically dependent, not using necessarily for the euphoria anymore. They're using just to feel normal. They live in a dysphoric state. And if you don't have the dysphoric state taken away, that withdrawal syndrome, you can't then move to the next step, which is to start recovery, to start learning about addiction, to get the support system in place, to work on things like safe housing, the rest of overall health.
MAT is vital for people who really need it because with withdrawal I would not have been able to do it. If I did not have access to MAT to be able to stabilize myself and get into treatment and hear a message and actually utilize the time that I was in groups and therapy sessions, I wouldn't be here. It would not have worked because my entire mindset and existence and everything would have just been focused on how absolutely miserable I feel. And I think that's something that a lot of people who have not experienced withdrawal, whether it's opiates, benzodiazepines, alcohol, you can't describe it to somebody who hasn't experienced it.
In rural communities where everybody knows everybody, a lot of times it's hard to even get people to come to treatment. So looking at that aspect of it is a critical area to take a look at how we can reduce the stigma associated with treatment so that more people will access care.
We have this wonderful tool, this medication that can help mitigate those symptoms and allow you to get the help that you need. So we need to do that right away. Like when it comes to this window of willingness that people who are seeking recovery have, seconds count.
So one of the things that's going on with the fourth wave of the opioid crisis that providers and pharmacists should know about is that people are more frequently mixing drugs, and they are also using a lot of stimulant medication, such as cocaine and methamphetamine. And in terms of the drugs that they're mixing, gabapentin and benzodiazepine type drugs are prominent and can cause a lot of problems. And also they're mixing drugs that they don't even know about because sometimes they're buying drugs on the street, even pills that look like FDA-regulated pills but are not. And these pills are counterfeit, and they've had various things added to them, most concerningly fentanyl.
When you mix drugs, depending on the drugs, you can get a lot of different effects, but most often when we see fatal overdoses or somebody ends up in the ICU, they're mixing depressants, and that includes most commonly an opioid, usually fentanyl, It could be from heroin, it could be from a counterfeit pill. But in addition to the opioid, another depressant may be used, like a benzodiazepine or gabapentin or alcohol even, or all of the above. And when you have several depressants combined together, you have a greater effect on decreasing breathing, the decreased mental status. The combinations blunt the ability to recognize that the oxygen saturation is low, so people are less likely to be breathing when their oxygen drops or when their carbon dioxide rises. The opioids, the synthetic opioids in particular, work very quickly, and you don't have a lot of time to recognize an overdose, in particular if someone's using intravenously. So, historically, if we had prescription opioids taken, we had a little bit of time for someone to recognize somebody's passed out on the couch, their breathing is slowed. Now it's very abrupt. Fentanyl overdoses happen really quickly. You have not as much time to react. Great risk of overdose if using alone. Xylazine has been around for a while, but just not in the United States, Northeast, and now it's showing up in the Northeast. Xylazine is a horse anesthetic. It is added to the heroin because it kicks it in, it potentiates it. If a user is using xylazine, it makes them more dependent. Now, if you're using heroin, whether it's fentanyl or truly heroin, and you have xylazine, the withdrawal syndrome is going to be a lot worse. The intoxication will be much more significant, and risk for fatal overdose certainly more significant. But if they stop using, they have much more severe withdrawal.
Gabapentin can be a useful medication for many problems, but when it's used together with opioids, it confers a higher risk upon the person. So people need to know about this problem. Actually, gabapentin misuse among the general population is on the rare side, but when you look at the opioid using population, those who misuse opioids or have an actual opioid use disorder, the amount of people who misuse gabapentin is increased. One of the very important things to do after you've talked to the patient and asked them about drug use disorder and also investigated the results of a urine test or mouth swab, the next most important thing to do is check the state prescription management program to see if they are getting prescribed any other opioids from other doctors or other or benzodiazepine types of drugs. And you can also see gabapentin reported in some of these prescription management program databases, not in 100% of states, but in certain states, it's been mandated to report gabapentin prescriptions as well because of all the problems with gabapentin. So examples of states that have mandated such type of reporting are Ohio, Virginia, and West Virginia. And there are several others as well. And there's movements in other states to get that legislation on the books.
It's important that we're educating people that are at risk, as well as the general public, family members, friends, to be aware of naloxone, to make sure that there's naloxone distribution programs available in those communities and that we're making it available to any and everyone.
It's really dangerous to use alone. The overdoses occur rapidly, and if you don't have someone there with naloxone, if an individual uses too much, really high risk for fatality.
So the first thing is the distribution of Narcan and making Narcan readily available. That's the first step. I think that it's important to note that, and I said this to a counselor one time, I was very high risk, I was still using, she gave me a Narcan kit, and I went, this is great, but if I'm overdosing, I can't Narcan myself. Which then kind of leads into the next thing, which I think we're doing, but we could do a better job, which is minimizing these feelings of guilt and shame around substance use disorder. Because that guilt and shame is what caused me to use in abandoned houses and alleys and alone in my car, where if I did overdose, there was nobody there to help me.
I'm talking with the person who's using drugs. I try not to lecture, treat them in a destigmatized way and try and make them aware that I'm here to help. Whether that's if they're not ready to stop using, to use safely. Then I teach them about things like needle exchange, use with somebody so you're not using alone. Test the drugs. If you're able to get fentanyl test strips, so you can understand that, know what you're using. Recognize the combinations that you're using could be more dangerous potentially.
Avoiding the fear-based messaging, where I'm not trying to explain what the risks are to scare you. This isn't a scared straight tactic. That doesn't work. What I'm trying to do is here's the realistic possible outcomes of what you're doing. What do you want your outcome to look like, and how can I help you reach that outcome?
I think the most important things for communities to do, of course, is working with their healthcare systems, their government officials to push and ensure that treatment is readily available.
It's important to try and provide as much treatment as possible and to make all of the opioid use disorder medications available to people. That's something that we can do if we have community willingness and provider willingness.